Okay, everybody. We're gonna talk about myocardial perfusion imaging, and this is going to be kind of a basic talk. This is what kind of happens behind the scenes in terms of acquisition of images and what you need to troubleshoot when you do myocardial perfusion imaging in terms of getting good images. So first of all, I'd like to talk a little bit about emission. So, you know, there are different kinds of particles. There are alpha particles, which is basically a helium nucleus. There are beta particles. These are electrons, and they can be positive or negative electrons. They can be positrons or electrons. And there are gamma rays, okay? And in nuclear cardiology, obviously, we don't image alpha particles because they can be stopped by a sheet of paper, and actually by tissue paper. And beta particles can also be stopped by just a piece of plastic. And so if you inject someone with a radiotracer, it doesn't really do you much good to try to image those kind of particles. So what we do image are gamma rays, which have a tremendous amount of penetration and can be imaged. Because remember, we're not emitting. We're not transmitting radiation through the body. We're actually getting emissions from the body. So the radiation has to be able to get out. So some basic nuclear physics here. There are different types of modes of decay in which we look at in nuclear cardiology. One of the fundamental ways is decay by beta emissions. And this is actually even though we don't image molybdenum 99, it actually is critical because when it decays by beta emission, you get technetium 99, which is what we use almost every single day, well, every single day in the lab. And in the old days, we actually used to have molybdenum generators in the lab. We used to milk the generators to get technetium. Nowadays, we just get unit doses, and most of you who do nuclear cardiology will do that. You'll just get unit doses from a radiopharmacy. But in the old days, we actually had molybdenum generators, and we used to milk it to get the daughter, which was technetium. The other thing is there's another type of atomic emission called isomeric transition, and this is from internal conversion. And this is another very common way in which we utilize nuclear cardiology, because when you go from a metastable state, a metastable compound like technetium 99M to a technetium 99M, which is a stable compound, you emit a gamma ray. And that gamma ray is 140 keV, and that's the 140 keV isotope that we image when we do technetium studies. And then there's also other things we utilize, such as electron capture. This is a kind of an interesting phenomenon, because what happens is when you have a protein-rich nucleus like you do with thallium, the nucleus actually absorbs an electron. And when it absorbs an electron, it leaves an empty shell in that electron cloud, and another electron comes down from a higher level, and that filling in gives off what we call a characteristic X-ray for that level. And thallium emission actually works that way. Thallium works by electron capture in terms of the way we image the gamma radiation. And thallium has a very characteristic X-ray of 72 keV, which we image, okay? And then we have another kind of emission we use in nuclear cardiology called positron decay. And positrons, as you know, when a positron hits an electron, it annihilates. It's matter, antimatter, okay? And you get an annihilation in 180-degree opposite directions. And that is a positron emission at a 511 keV, so it's very high energy. So there are different positron emitters, such as rubidium and FDG, et cetera, fluorine. And they all have their own separate energies. But when they send out positrons, those positrons, even though they may have different energies, when they annihilate, they always annihilate at 511 keV. And it's 180-degree opposite. And we'll kind of go through some of that. So in nuclear cardiology, there are many different, in physics, nuclear physics, there are many different kinds of interactions that occur. These are some of the things that we actually don't image. And one of them is called excitation. And excitation is simply when a particle, not a photon, not a gamma ray, but a particle comes near another electron and excites it to a different level, to a higher level, and that causes emission of energy. There's also something called a characteristic X-ray. As I told you, with gamma rays, you can actually, they're formed by characteristic X-rays, okay? Emissions. But you can also do it with charged particles. So you can have an electron come near an atom, and it can displace, it can kick out an electron. And that particle then comes down and gives off a characteristic X-ray. And then there's another type of emission called breaking radiation, which is Bremsstrahlung. I always have a hard time, it's a tongue-twisting name. But it's called breaking radiation because a particle comes near the nucleus, and as it slows down as it gets near the nucleus, it gives off energy. And even though this really has very little application in nuclear cardiology, it actually has a tremendous amount of application in CT, because in CT, we actually use ionization, which is characteristic X-rays, and Bremsstrahlung, which is the most common type of X-ray that we image when we do CT imaging. So even though in nuclear cardiology doesn't have a lot of practicality, in CT imaging, actually these kind of emissions are exactly what we use. And in fact, when you think about a CT scanner, what you do is you bombard a target with electrons. And when you bombard a target with electrons, you kick off an electron out of the outer shell, and you create a characteristic X-ray. And also these Bremsstrahlung as the electrons go around the nucleus of that target material, usually tungsten or something like that. So CT actually is based in this. In nuclear cardiology, we have three major interactions, and they're all photon interactions when you think about it in tissue. So we create these photons, and they come out of the body, okay? And one of the ways we do it is with photoelectric effect. And that's basically where a gamma ray comes in, and it kicks out an electron, and again causes a photoelectric event, which is a characteristic X-ray, a certain amount of designated energy that comes off, and that's done with the gamma ray. There's also, and that's actually in tissue and in crystals, and we'll talk about the sodium iodide crystal as a way of being able to measure these photoelectrons as they come off the crystal. There's also very commonly and unfortunately Compton scattering. Compton scattering occurs mostly in tissue, unfortunately. And so if you give thallium or you give technetium, what will happen is you'll have different gamma rays, different photons hitting material and not being absorbed, but simply being bounced off in the tissue into different angles. And that can cause a lot of reduction in spatial resolution, which degrades the images. And then, of course, we have pair production, which is the generation of positrons. And positrons are critical to the use of positron emission tomography. So the photoelectric effect, as I said, the photon hits, it comes into the atom, it's absorbed, and you kick out an electron, and you get a characteristic X-ray based on the binding energy of that electron to the shell in which it was kicked out of. Then you have Compton scattering, and you can see that as a photon goes in, it then hits something else, it's deflected, and goes in a completely different angle, a different direction. And depending on the scatter angle, you will lose energy. So the greater the scatter angle, the greater the loss of energy. And it turns out that the higher the energy of the photon, the less energy that's lost per angulation of scatter. Okay, so that's important because when we image over a certain photopeak, and we'll talk about that, we like to use a 20% window over let's say we're using technetium, which is 140 kV. We'll accept 20%, 10% on either side of that 140 kV. If something scatters minimally, like technetium, you'll lose very little energy, and you may pick that up even though it's a scattered photon, and that will degrade your image. With thallium, you actually if you have greater degrees of scatter, you completely lose energy there, and you don't accept those photons. So the greater the angle, the greater the energy lost, and as I said, you can have multiple angulations. With PET imaging, as I've already alluded to, there are many different PET tracers, and you emit obviously a positron. These are positron emitters, and they hit an electron and they annihilate each other in 100-degree angle, separate angles, to form an image. And they're all 511 keV, irrespective of the initial energy of the positron emitter. So, for instance, F18 has an energy of 0.635 MeV, which is relatively low, whereas rubidium has a very high energy of 3.35 MeV. And why is that important? Because with rubidium, because of its high energy, it has a very long positron range. And so what does that mean? That means it travels through tissue further from its origin until it's annihilated. So rubidium inherently, as a tracer, has worse spatial resolution than an agent like F18, which is very low energy and annihilates very close to the source in which it was emitted from. Okay? This is just an example of Compton scattering where you have many different scattered photons. So you can see you have a scatter event happening here, then the gamma ray goes off and scatters here, and then comes back down and scatters again. And finally, you have a photoelectric effect. Maybe it finally hits a crystal or it's absorbed, depending. And so you can have a lot of scattering in the body, and that scattering in the body, as I said, is really one of the problems with nuclear cardiology in terms of causing degradation of spatial resolution. This is also a very important figure because it looks at where photoelectric effect occurs and where Compton scattering occurs and where pair production occurs. Pair production we're not so interested in, but Compton and photoelectric we are. And it shows you three different levels. Now, the Z number is the number of protons in the nucleus, and it defines the element. So protons define the element. So lead has a very high Z number. Sodium iodide crystals have a lower Z number, and tissue has a very low Z number. It's like 15, okay? If you look across at the different types of agents that we use, the red bar looks at technetium. And you will see that in tissue, therefore, with technetium, almost all interactions with tissue are Compton scatter effect events, which is very bad because we don't like scatter. With thallium, it's the same way. That's the blue bar. Any interaction with matter in tissue is going to be, generally speaking, a Compton scattered effect. Then we look at the sodium iodide crystal. Remember, the crystal is what we use to image people, and there we want to have photoelectric effect. We want to have absorption of the photon and generation of a scintillation, a light scintillation, okay? And you'll notice that for both thallium in blue and technetium in red, the majority of events in a sodium iodide crystal are not Compton. Not that you can't have some, and I'll show you that, but most of them are going to be photoelectric effects, which then cause an absorption of the photon, and then release of energy in a scintillation, a light event, which is then registered and picked up by the instrumentation. In lead, you'll also notice, which is very dense, that almost all events are photoelectric events. There's no scatter in lead. Lead absorbs, which is one of the reasons why we use it in the laboratory to protect ourselves from high levels of radiation, right? Okay. And just also remember that photon attenuation depends on three major things. The photon energy, so the higher the energy, the more penetration there is. The material density, that's the Z number, okay? That's like the difference between lead and some other compound, and the material thickness. So the thicker the material, the less likely it is that photons will get through and they'll undergo a photoelectric event and be stopped, okay? And again, I want to emphasize that with thallium and with technetium, the primary interactions we have in tissue as these radiotracers, these emissions are coming off the patient, are Compton scattered events. So it's not that technetium is any necessarily better than thallium in terms of better imaging because there's less Compton scattering. There still is a tremendous amount of Compton scattering in tissue with either of these radioisotopes when they're emitted from the source and come through the body. Okay, so the whole idea is that we have to have photons get out of the body and be able to hit a gamma camera so that we can record a scintillation or record an event. And then we have certain instrumentation to help us determine where that event occurred. So the scintillation comes off. There's something called a lead collimator. We'll talk more about this in terms of how it directs photons. Then we have the crystal. For nuclear cardiology, it's typically sodium iodide crystal, but there are new CZT, cadmium zinc telluride crystals that we're using today. Today, actually, we have one of those systems in our laboratory. And then there are these things behind the crystal called light detectors, which are PM tubes, photomultiplier tubes, that actually take each scintillation that occurs, each photoelectric effect that occurs, and amplifies that so that the machine can determine exactly where the scintillation occurred, and we can then determine an image or develop an image. Let's talk a little bit about collimators. As I said already, collimators are used to direct photons. And so there are good photons and there are bad photons. Bad photons are those that are not parallel to the holes. I mean, good photons are those that are parallel to the holes of the collimator. Bad photons are those that are not parallel to the holes of the collimator. So as you can see here, here's a photon coming through. These collimators have lead, and then a gap, and then lead, and then gap. These are lead septum. And so if a photon is parallel, it can go through and hit the crystal and record it as a scintillation. However, if this is way off, it will come in instead like this and be absorbed by the lead and not hit the crystal. And the reason for that is because if you're trying to make an image, you want to make sure the photons that are coming off are not scattered photons. They're photons that are directly coming from that part of the organ directly into the camera head, not photons that are coming from here and coming from that direction and the other direction. So the collimator focuses the photons into the proper orientation. We use this term called full width half maximum, which determines the resolution of any system. And we talk about full width half maximum, we talk about energy resolution, when we talk about collimator resolution. And what it simply is that if you had a point source, you're going to get a distribution of that point source in terms of the width of it. Okay? So if you have a point source that's 1 millimeter, you're not going to see, and you image that, you're not going to see 1 millimeter. You're maybe seeing 5 or 7 millimeter diameter, okay? And that's going to be the width of the point source. And we use the full width half maximum, which is half the height of the full width of this, as the intrinsic resolution of the system. So we can actually measure what this half maximum is in order to determine what resolution for the system will be. So take this for example. This is actually, this yellow bar here is a half maximum. It would be the same as this here, okay? So if you have 2 points in space, 1 point here and 1 point here that you're imaging, what this means is that these 2 points are far enough apart where they would actually be distinguishable from each other. They would be distinguishable because the distance between them, the point sources, is greater than the full width half maximum determining the resolution of the system. Okay? But on the same token, if you had something like this, where now you have this full width half maximum, you have a point source here and a point source next to it, right? Now you'll notice that the distance between these point sources is less than the full width half maximum. So what you would see is just a blob. You would not see 2 independent points anymore. So your resolution would be markedly reduced, right? I mean, you wouldn't be able to distinguish 2 points anymore. you would just see one big blob point because the resolution of the system was such, based on the distance between the points, that you couldn't resolve them. Okay? So full width half maximum is a very, very important point. Remember that when we're thinking about collimators, that the resolution is determined by the diameter and length of the collimator holes and by the distance that you sit from the face of the collimator. Okay? So if the holes are very narrow, you'll have, or very narrow in diameter, you'll have improved spatial resolution. And if the holes are long, you'll have improved spatial resolution. And if you bring the patient closer to the camera head, you'll have improved spatial resolution. The other converse of that is collimator sensitivity. Collimator sensitivity is a reflection of the number of gamma rays that actually hit the crystal, that pass through the collimator and hits the crystal. So it makes sense that resolution is inversely proportional to sensitivity. The higher the resolution, the less of those photons are actually going to hit that collimator head. Okay? And of course, that's important because if you have less photons, you have to image for longer periods of time so that you get a reasonable looking image. So again, you increase the hole diameter, you decrease resolution, you increase sensitivity. You increase the hole length, you increase resolution, and you decrease sensitivity. Septal thickness doesn't really have much of an effect, but again, the source to collimator distances do. So if you want to improve resolution, you bring the patient closer to the camera head. This is just an example using just one type of collimator. This is using ultra-high resolution versus high resolution versus low energy all-purpose versus high sensitivity. And you can see what the sensitivity is compared to the collimator resolution. Okay? So you'll notice that as sensitivity goes up, in other words, as the number of counts per millicurie injected go up in terms of what you're seeing, you have worse and worse resolution. Okay? So they're inversely proportional. Here's an example of where distance makes an important point. So here's that typical point function that we talked about earlier. Okay, this is a low energy all-purpose collimator. You can see the collimator holes. Here you can see that the point source or the patient is close to the collimator. And look at the full width half maximum here. It's pretty narrow. But now let's move the patient further away. Let's double the distance from the collimator head. And look at the full width half maximum now, how much wider that is. Okay? So that's why it's much better to bring the collimator, the patient closest to the camera head, in order to improve your spatial resolution for any given collimator that you might use. The other important thing is look at high resolution collimators here. Now, high resolution collimators, as you can see, have smaller diameter holes than the low energy all-purpose collimators, and they have longer bores. Okay? And so the spatial resolution improves. And look at the full width half maximum here with a high resolution collimator compared to an all-purpose. Okay? So the type of collimator and where the patient sits in terms of closeness to the collimator head makes all the difference in terms of improving your spatial resolution. So for all types of collimators, resolution degrades as the object moves away from the collimator face. And if you don't remember anything else, this is very important because we see this in the lab all the time. You know, it doesn't improve the number of counts bringing the collimator closer to the patient. That doesn't improve. What it does improve is the spatial resolution. And that's why we try very hard when we do nuclear imaging to make sure that the camera head contours the body so that the camera is as close to the body as possible. And again, here's the same kind of situation in terms of looking at a point source and looking at what the full width half maximum would be with the collimator close versus the collimator far away from the patient. And this actually works for all types, as I said, all types of collimators. This is a high resolution collimator. This is a general purpose collimator. But again, you can see that resolution gets worse as you get further and further, as the patient gets further and further away. Very important concept to remember. Okay. So now we're going to talk about what happens actually with these in the crystal, etc. So We have the crystal material, which is sodium iodide. We have these light detectors, which are photomultiplier tubes, which amplify all the scintillations, all the photoelectric events that occur, all the ionization events that occur. And then we have a voltage. We can register the voltage, and we amplify that voltage, and we discriminate that voltage, which what we call a pulse height analyzer, okay? And then we can display the image. Now, it's often thought about what's the best thickness for a crystal, and actually there are some optimized thicknesses of crystals. If the crystal is too thick, it really doesn't help you, because you can see that in terms of detecting photons, scintillations, the thicker you get, after you've reached a certain level, you asymptote and you don't get any better registration. If the crystal is too thin, then photons will pass through the crystal. Remember I talked about the full width half maximum. If the material is too thin, photons will go right through, even if it's a high Z number, even if it's a dense material. If it's too thin, photons pass right through and you don't register anything. Okay? So it's important to have a certain amount of thickness, and every single system, whether it be a PET system or a gamma camera system for SPECT imaging, there's a certain crystal thickness that is used to optimize the radiotracers that you are utilizing to image the patient. The other thing is that when we talk about different radiopharmaceuticals, we talked about thallium and we talked about technesium. We don't use a lot of thallium anymore. We're using mostly technesium. And we said that the most common event to occur with thallium and technesium is Compton scattering in the patient. So scatter occurs irrespective of the radiotracer you use. But one of the things that is good about technesium, okay, is that at the level of technesium, the full width half maximum, or the energy resolution, the narrowness of the full width half maximum in terms of energy resolution, is greater with technesium than it is with thallium. So you can discriminate individual energies and count those energies and be confident that those energies are what are really the actual energies you need to make an image much better with technesium than you can with thallium. And so that's one of the reasons why thallium is not such a good agent. It's got very poor energy discrimination in terms of its full width half maximum. And so if you look at the typical photons coming through and you want to look at the different energies, obviously we put a window around the photo peak of the isotope we're imaging. So for technesium, it's going to be 140, and we have this energy window of 10% on each side of 140. So these are the photons that we try to register. The other ones we ignore, okay, because they're below the energy. And the reason why we ignore them is more than likely, since technesium was being injected in the patient, they should all be 140. But that's not the case, because of Compton scattering, the energy will degrade and will degrade down to a level beyond the window where we wouldn't accept them. And that's important because we don't want to accept scattered photons. So this is the photo peak, and every day of the week we peak our cameras to make sure that our photo peaks are aligned on the agent that we're utilizing, whether it be technesium or thallium. And so this is 140 kV, and we have a 20% window, 10% on each side, and all this is what we image. All the rest of this is Compton scattered events. And in fact, there are a lot of Compton scatters that occur, and you can see some of them might even be accepted by the crystal. So if you look at this, this is actually a good photon. This photon comes off the patient, goes through the collimator, hits the crystal. It's going to be 140 kV. It's going to be registered, and the position of that scintillation is going to be recorded. Okay? But what about this guy over here? What if this is a Compton scattered event? What if you have this here, and it scatters over here, and then it comes in? Or what about this? This is like a second order Compton scatter. So you have a photon that's emitted, it scatters again, but it still hasn't maybe enough energy to hit the crystal and cause a scintillation. But because of the energy window we use, we will not include this in our image, because that would be bad if the event occurred here and it was recorded in the crystal here. You can see how the spatial resolution would be markedly degraded. Okay? So even though this particular Compton scattered photon could interact with the crystal, could get through the collimator through some, back and forth nonsense, finally getting a parallel way in, and hit the crystal and cause a scintillation, it would not be recorded because it doesn't meet the energy requirements to be recorded based on the pulse energy width. Okay? So you can see this is a typical photo peak, and these are all Compton scattered events that are outside the photo peak. And of course, these would not be accepted. Only the ones within the window of 140 kV for technetium would be accepted as forming the image that we want to see. With newer crystals, we actually get even better energy resolution. And this is one of the advantages of CZT crystals, cadmium zinc telluride. If you look at the energy resolution of sodium iodide crystals, it's about 10%. Okay? That means that if you look at the full width half maximum, there's going to be about a 10% difference on either side in terms of being able to distinguish what's a good photon and a bad photon. If you look at CZT, it's down to 4.5%. So if you have 140 kV photon, that means you'll only accept 140 kV plus or minus 5% in terms of that the camera will be able to distinguish and be able to say those are the ones we're going to take as being acceptable. So you improve your energy resolution, and again, therefore by improving your energy resolution that the photons you're accepting are more than likely photons that came directly from the patient, parallel right through the collimator and hit the crystal. Okay? Okay, there's another concept that we have to talk about, and that's energy correction, because it turns out that in different parts of the crystal, in different photomultiplier tubes, you can get variations in terms of these Gaussian distributions. Okay? And so the photo peaks may vary depending on the photomultiplier tube that's being imaged. Okay? So for instance, here we might have a peak of about 150, here it would be 140. And so what we need to do every day when we correct for this is correct for any differences so that everything is aligned, so that all the photomultiplier tubes are aligned. Why is that? Because we don't want to have non-uniformity. We don't want to have non-uniformity in our crystal and in our electronics in one part of the image compared to the other, right? So if this is the, let's say, the anterior wall of the heart here, if it's recording less energy, we may get a defect compared to over here where it would be, hotter. And so this is just where we do energy correction. And you can look at this image and you can see where doing correction of energy in terms of aligning the photo peaks really helps. So this is a typical gamma camera face. You can see how low some of these energy peaks are and how much higher they are in other areas of the crystal. But when you do energy correction, now they're uniform. So now all the photomultiplier tubes are aligned, and those energies that come off the patient are going to be accurately assessed for all parts of the image that's being created. Okay? So let's talk a little bit about the different things that we do in terms of uniformity, spatial resolution, and center of rotation in terms of the gamma camera itself. So uniformity is basically making sure that the gamma camera displays the radiation equally over all parts of the crystal face, of the gamma camera face. And this is important because it's important to remember that no crystals are perfect. All crystals have imperfections. If a gamma ray hits a certain crystal, it will react in a little different way as compared to another part of the crystal. And so you have to correct for those non-uniformities in the crystal itself. We live in an imperfect world, okay? And the way we do that, and there are two ways, we do integral uniformity, and we have this thing, and differential uniformity. So integral uniformity, we simply look at different points, the major, the highest and the lowest values of pixel values across a camera face, and we determine what the difference is. That's integral uniformity. And then we also have differential uniformity, where we go across a row of pixels and determine the greatest difference in a row of pixels. That's more like a local neighborhood area of uniformity. And so we like to have uniformity under 5%. You should have at least no more than 5% non-uniformity in a crystal. And by knowing what your crystal looks like, you can then correct for these subtle differences in the crystal itself to make a uniform picture. And so you can see that, for instance, this is a fairly decent looking crystal in terms of the uniformity. And look at this crystal. See how blotchy it is in terms of the surface? And this would be considered a lot of non-uniformity, which would degrade the image. Okay. There are two types of uniformity that we look at. We look at intrinsic measurements, okay? And intrinsic measurements are without the collimator. And we look at extrinsic measurements, which are with the collimator on the camera surface. Generally speaking, every day of the week, we do extrinsic collimation. We do extrinsic uniformity measurements with the collimator on, using normally a cobalt source. Cobalt, the cobalt photon is very similar to that of technetium. It's 123 compared to 140 with technetium. So cobalt becomes a nice way of being able to flood your cameras and be able to look at uniformity. And then once a week, we do a flood source with a small amount of technetium with the collimator off to get an intrinsic measurement to correct for the cameras. There are many causes of non-uniformity. You can have crystal damage or crystal imperfections. You can have PM tube failures. You can have a lot of electronic problems. You can have incorrect energy windowing, etc. So all of these things, when you do your uniformity correction, if your uniformity is good, you don't have to worry. All of these things are not going to be in place. If your uniformity is bad, then you have to go through all of these different things and figure out why it's bad in terms of getting an improvement. So uniformity is one thing we do. Spatial resolution and linearity. This is another important concept, because PM tubes, which measure the scintillations and amplify the scintillations to give us an image, they sit behind the crystal, and they register the scintillations that occur. It turns out that the output function of those is not constant across the PM surface face. And so when you do a flood correction, you've got to do linearity correction for the PM tubes. And you can see how you get from there to here by doing linearity correction. So very important. And then what we do bar phantoms to be able to look at linearity in a semi-quantitative fashion in terms of being able to determine if there are any breaks in lines when we image, or if we're able to distinguish the smallest amount of bars, which would be the greatest amount of spatial resolution. So we put a bar phantom on the camera head. We have a point source or a cobalt source, which we flood through it, and we're able to get a picture like this to determine the resolution. And then finally, center of rotation. Now, in some of the newer systems that have fixed gantries, it's not a problem. But in our typical gamma cameras that have two heads where they rotate around the patient, if they're off sync, then you'll get distortion in the images. Okay, so you have to have everything uniform going around the patient in terms of the gantry. And so this is just an example of what you might see. You can see this is where there's no center of rotation error. And this is where you're a pixel and a half off, and you can see the gap. Well, you might call that a perfusion defect. It's not. It's due to a center of rotation error, okay? So center of rotation errors are important, and we do this on a weekly basis. We do a center of rotation with a point source to make sure that when you image a point source, you see a point source. You don't get this donut because of a center of rotation error. So there are a lot of things that go into quality assurance. We talked about the fact that, generally speaking, uniformity is pretty bad. It's like 20 to 30% non-uniformity if you do nothing. If you add energy resolution, you improve it a little bit, but you do it mostly by adding linearity to it and by adding your daily floods, where you can get down to 2 to 5% non-uniformity. So that's what we do every day when we flood cameras, and it's important when you read studies that you take this into consideration in terms of what the floods look like, etc., so that you know the image you're seeing is reliable and not just due to artifacts. Okay, now we have an image. What do we do with it? We have to create it. Okay? And we do that by filtered back projection. Remember, when we do imaging, we have like 64 stops. So we have 64 images, and we're looking at the heart in all different places, right? All different positions. And all of these triangulate back. They all back project to form a three-dimensional image. So this is just an example. If you just had one view of something, you might see this. If you had two views of something, you might start to see a box like this. If you had four views of something, well, now where all these intersect, you might actually start seeing some kind of image. And if you had 8 views of something, now you can see where all these lines intersect, you actually start to form an image. So imagine if you had 60 or 64 views of something. You can see how you now would get a very nice three-dimensional view of the thing you're imaging. What about filtering? Filtering is very important because once you've back projected and you have an image, then you have to filter it. Everything is filtered. In CT, we filter everything too. We use iterative reconstruction. We use smooth filters. We use sharp filters. There's all different kinds of filtering that's used in order to improve image resolution. This is different than spatial resolution. Spatial resolution is determined by the camera itself, okay? By the collimator, by the energy that you're imaging in terms of the full width half maximum. But image resolution is determined by the filtering, okay? So we kind of fiddle around to see what's the best cutoff frequency we use. So here's an example. Here's an original image. Here I'm starting to remove high frequencies. Here I've removed, in the bottom left, even more high frequencies, down to medium frequencies. And now I've removed all frequencies except for low frequencies. Well, if you had a myocardial perfusion, if you had a heart like this, and you came out with this image, I don't think it would be very helpful. Okay? Not much you could tell. Okay? And that's because we removed all the high frequencies. And what are high frequencies? High frequencies are changes. There where changes occur, and they're most easily, the best way to explain it is when you see edge detection. I mean, when you have a flat surface and you come to an edge, and now you come off that edge, that's a high frequency change. A flat surface is a low frequency change, okay? So if you just had low frequencies, you wouldn't be able to see anything, no detail. So you have to incorporate some high frequencies into your image in order to see it. Resolution, as I've already talked about, is determined by the collimator and the crystal and the energy resolution, but it's also determined by the pixel sizes that you use in your image. So the more pixels you have, the more information you have. The more information you have, the more the image resolution will improve. Okay? So again, it's the difference between spatial resolution and image resolution. So this is, the more pixels you have, the better your image resolution. So you can see the difference. But here, this is a 320 by 250, and this is 43 by 43. You can see the difference in terms of granularity with just a small pixel, with minimal pixel sizes. So remember that all filters remove information. We optimize our filters based on a guess. And it's subjective. And when you overfilter, you can destroy information. So here's an example of a heart that's now been filtered back projected, and now we're going to add filters. So this is using just this is including all filters. This is high frequency, medium frequency, low frequency. Very grainy, right? Very noisy image. Okay, now we're taking some of the high frequencies out, more of the high frequencies out. Now we've got nothing but medium to low frequencies, and now it's very smooth. But you can see that from here to here, we might lose our ability to resolve a perfusion defect, because now we've imaged out the defect. The contours, the edges of the defect are now gone. It's all been smoothed over because we removed the high frequencies, okay? So we have to pick the right frequencies in terms of being able to do it. The other important thing is that counts mean everything. The more counts you have, the better the image you have, the less noise you have. Okay? So for instance, if you have 100 counts per pixel, okay, your noise will be 10%. It's basically 1 over the square root of 100. That's how you determine noise. So that would be 10% noise. Okay? If you have 10,000 counts per pixel, now you only have 1% noise. Okay? So the more counts you acquire, the better the image quality will be. But remember, we also talked about all these trade-offs, because we like to use a low energy, high resolution collimator, which has long bores, okay, and narrow holes, so that we only get the best photons into the camera. But by doing so, we eliminate most photons. So how are we going to get an image? It means we have to usually image longer, okay, to get an adequate amount of counts. Because if you don't have enough counts, you don't have an image. And incidentally, that's the same thing with every other imaging technique. CT, we had a fellow yesterday who was like 350 pounds and couldn't see anything. Even at 140 kV, trying to penetrate. I mean, basically everything looked the same. You couldn't resolve, because the number of counts getting through, or the amount of radiation getting through to attenuate, was so minimal. It was all being attenuated in the soft tissues. So there's no image. It's all whiteout. Okay? So you have to have counts to make an image. Irrespective of your imaging technique, you have to have counts. The more counts you have, the better the image you'll have. Okay? So this is a typical image, and I think I have like maybe 5 more minutes or so. I'm going to talk a little bit about, once you have an image, once you've done your filtering, now how do you look at an image? Okay? You always do STINI displays. Every single time you read a myocardial perfusion scan, you need to look at the raw data first. Okay? Because you need to look and see if there's any vertical motion, horizontal motion. You need to see if there are adequate counts in the image. You can see the heart here. Whether there's been any infiltration of dose, whether there's extra cardiac interference, such as liver or gut, etc. Okay? So you need to be able to, or attenuation. So you need to be able to look at all of that. Motion is problematic. Motion can cause a lot of artifacts. You can see in this particular image with motion, there's a little anterior defect here. There's a defect here at the base of the heart. There's a little apical defect here. All of that goes away when you do motion correction. Motion correction is something we use in nuclear cardiology, and there are algorithms to correct for motion, but unfortunately, they are imperfect. And so it's really best to get a motionless image than get an image where the patient is moved and then try to correct it. Okay? And so a lot of times with technetium, we have to re-image people. And we can do that, thank God, with technetium, because technetium doesn't redistribute like thallium, so we're able to re-image and re-image if we need to get a better picture. Y-axis motion, up and down motion, we correct pretty well. X-axis motion, we can't correct at all with any of the different algorithms. Even though people may claim, we really can't. Breast attenuation and other attenuation artifacts are something we also look for. It's very important when you image patients that you have consistency in imaging. So if you're imaging women and you have a certain breast positioning on the stress images, they need to be the same on the rest images. Otherwise, it will be apples and oranges, and you will not be able to distinguish what's artifact and what's real. Okay? This is just an example of differing breast positions. You can see in the stress images up here, the anterior wall looks abnormal. On the rest images, the anterior wall looks normal. Well, this patient just had breast attenuation, but it was called ischemia. okay, because it improved on breast imaging. It was all just artifact. So it's very important to make sure of that. And you can see even on these images over here, where on the first set of images, half the heart is covered over by the breast, and on the rest images, the heart is completely overshadowed by the breast. So it's very important to look at your raw data. If you have a technologist that comes with this data and you see this, you say re-image the patient, because that's just not good. That's just not proper. Okay. Just another example. Diaphragmatic attenuation is another thing we commonly see. It's more common in males, although we see it in females. It's more common in obese patients because the belly pushes up and the diaphragm pushes up and the heart sits in the belly of the diaphragm, basically. And it's more common in the inferior wall. Nowadays, what we do, we can do prone imaging. We can do attenuation correction if you have attenuation correction techniques. We can also do supine and prone imaging. This is an example of someone who had supine imaging, where you see an inferior defect. And then on prone, putting the patient on the belly, the defect goes away entirely. So you call this patient normal, okay? And you don't need rest imaging anymore. And you can see that this patient did indeed have diaphragmatic attenuation. Whoops. As I guess may be shown on this slide, I don't know. Somewhere on here. Anyway, he had diaphragmatic attenuation over the inferior wall. Adjacent liver activity is also very important because it can do one of three things. It can contribute scattered photons into the myocardial walls. It can obscure walls by overlying them so you hide a defect, or it can create what we call a ramp filter artifact, which is something that is caused by adjacent hot activity. This is scatter. This is scatter of photons into the inferior wall. There's no way anybody could read this inferior wall in terms of a perfusion defect because of the high subdiaphragmatic count activity. Ramp filter artifacts are due to the inherent, the inherent method that we use the ramp filter. So we do filter back projection and then we do ramp filtering as a way of doing our frequency adjustments. There are now other ways of doing this with iterative reconstruction that can actually avoid these kind of artifacts. But just to show an example, this is a patient where there was a big perfusion abnormality here due to a hot liver. And we will re-image the patient. It completely went away. And this was all just a ramp filter artifact. One way you can do this instead of re-imaging the patient is simply to go from a filtered back projection with a ramp filter and use iterative reconstruction instead. So, next time, we'll talk about beyond image. We'll talk about stressors and isotopes, the different types of isotopes we utilize and why some are good and some are bad, and some of the clinical applications. But I hope this gives you at least some idea of when you're looking at a scan, all that goes in to creating an image. It's not just lying the patient on their back and putting a camera over their body and taking a picture. There are many, many things that go on behind the scenes in terms of the physics behind all of this and in terms of the resolution issues that you need to be aware of if you're going to read images properly. Okay? So, any questions before we finish? All right. Very good. Thanks.